Good morning or afternoon, depending where you are in Canada, and welcome everyone. Thank you for joining us today for Osteoporosis Canada's webinar, Breaking Myths, Not Bones. We'd like to begin by acknowledging that we're on, and this webinar is taking place on Treaty 1 land and home of the Métis Nation. My name is Pat McCarthy-Briggs. I'm a fracture prevention education volunteer for Osteoporosis Canada, and I'll be your moderator today. Before we get started, we'd like to let you know that due to COVID-19, there's a lot more usage of virtual platforms, such as the one being used by this webinar. And the systems have occasionally been overloaded or shut down and falter. Should we experience such an issue, please bear with us. We will have a technical difficulty slide to show you and attempt to fix it. So for today, there are still an awful lot of myths out there about osteoporosis, its care and treatment. Today, we're going to talk about some of those with our special guest panelists as they discuss and dispel the most common myths in their area of expertise. Before we begin, please note, on the right-hand side of your screen, or if you're using an iPhone, there may be a question icon at the bottom of the box. You can enter your questions at any time. It doesn't have to be during the time that the speakers are addressing their topic. If you've got questions right now, they can be answered. We ask that you keep your questions relevant to the topic being discussed, and note that we can't provide medical advice or answer specific individual questions. And I just also want to mention now, and I'll mention again later, that we may not be able to answer all questions. We will address the ones we received today during this hour. On the next slide, we're going to meet our Mythbusters. Our first Mythbuster is Dr. Bill Leslie. Bill is a professor of medicine and radiology at the University of Manitoba with over 350 peer-reviewed publications. His research interests are in fracture risk assessment, osteoporosis testing, and other nuclear diagnostic techniques. Bill is chair of the 2020 Clinical Practice Guidelines in Osteoporosis, which are currently in development. He's also the director of the Manitoba Bone Density Program and co-director of the Winnipeg PET Imaging Center. Michelle Glass, our second Mythbuster, is a pharmacist and a practicing community pharmacist as a business owner for the past 17 years. She's also certified as a geriatric pharmacist. Michelle has been a valuable volunteer as an osteoporosis educator for the last 10 years and is always willing to share her expertise at educational events and with community members. On the next slide, our third Mythbuster is registered dietitian Amanda Hamill. She is a nutrition educator at Dairy Farmers of Manitoba, where her primary role is to provide training and nutrition programs to Manitoba teachers so they can help kids feel comfortable around food and eating. Amanda is a strong supporter and volunteer for Osteoporosis Canada and generously shares her expertise at committee meetings and educational events such as this one. Emily Hunter, a registered physiotherapist, will be our fourth Mythbuster today. She has a special interest in osteoporotic clients. As a founding member and long-standing volunteer of Osteoporosis Canada in Winnipeg, Emily continues to educate the public and medical professionals in treatment of osteoporotic clients. On the next slide, we're having a look at what osteoporosis does. As an organization, we support individuals. We support individuals with programming in bone health education, osteoporotic treatment and care, and support individuals who have already been diagnosed with osteoporosis to help them improve their quality of life. The second paragraph on this slide describes our scientific advisory committee, which is made up of the experts and researchers in bone metabolism. The Scientific Advisory Committee board and staff issue medical guidelines and ensure that all our information is current and based on up-to-date research. It's important to note that what you're going to hear in today's webinar is based on science. There's research behind statements made and issues discussed. The webinar this morning or this afternoon, we're going to spend a little bit of time talking about bone health and osteoporosis, and we will then move on to looking at each of those four myths for a little bit less than 10 minutes per myth, and then the last 15 minutes, the participants take over where we will address your questions directed to the health professional on our myth panel that can best answer you. So first of all, we're going to have a look at bone. And the next slide compares bone structure to the structure of a bridge. And you'll notice that there's a great similarity between this tissue, the alignment of the cells horizontally across and supporting the structure across the curve of the bone. The combination of that protein framework hardened by minerals gives bone tissue flexibility and strength, similar to what you see in the bridge. Also note in the picture on the left-hand side of the bone that there are two types of bone. The outside, or what you see as white bone, called cortical bone, it's the dense, compact outer layer. And the trabecular bone, or the honeycomb structure on the inside. And it's that honeycomb structure that we will be looking at in more detail when we talk about sites that are at higher risk for osteoporotic fracture. Two terms that you're going to hear mentioned in the next hour: bone mass and bone density. The amount of bone tissue an individual has is called bone mass. The density of bone, or bone density, refers to how compact bone structure is. Now, if we could take a look in more detail inside that bone structure, obviously there are many, many cells, but the two cells specifically that we'll look at today are called osteoclasts and osteoblasts. And if you look at this cartoon schematic, or the diagrams here, you'll see on the left-hand side cells called osteoclasts create cavities, and all of those C's make that easy to remember. Osteoclasts create cavities. So these are cells that throughout the body, as long as we're alive, are moving from site to site on bone, removing old bone tissue. In the middle, you have the osteoblasts, and again, osteoblasts build bone, so that's easy to remember. These cells in the center are laying down a protein structure, and in the third box, where the repair is complete, the mineralization takes place. And one way of thinking about this, or a comparison that we would all have seen, is a road repair crew, where when the concrete begins to fail or is no longer strong enough to do its job, the guys with the jackhammers come along. These would be our human osteoclasts, removing the old concrete. Rebar is laid down. That would be the center box of that protein structure. And then the cement truck comes to fill the cavity, and the crew moves on to do the same thing again in another site. If the activity of these two cells, the bone removers and the bone builders, was equal throughout the life cycle, we would always have the same amount of bone. We'd have the same amount of bone, when you're 80 as when you were 8. The activity of these two cells is not the same, and bone mass changes throughout the life cycle. So on the next slide, we have a graph. And across the bottom of the graph, age in decades, going by 10-year increments up to 80, and up the left-hand side, amount of bone. And you can see that bone mass increases sharply up to about age 20. The line of that graph goes up remarkably. So during those years, the osteoblasts, or the bone builders, are more active than the osteoclasts. More bone is being built than being removed. From about age 20 to age 30, the activity of those two sets of cells is the same. And you can see that we've reached what's called on the slide peak bone mass. And that simply means, the most bone you're ever going to have in your life. After age 30, the osteoclasts become more active than the osteoblasts, and we begin to lose bone gradually at about 0.5 to 1% per year. Bone loss is normal. This happens to everyone, men and women. You can see that at menopause for women, there's a bit of a dip in that line, and bone loss increases to about 2 to 3% per year for a period of time, and then levels out to that same 0.5 to 1%. You'll also see that on this slide, there's a peach-colored section there that is called increased risk. And what that means is that that individual, or in this population, these individuals have lost enough of their bone mass that they are now at increased risk of fracture. And that means they have osteoporosis. In the next slide, we can see a definition of osteoporosis. Okay, and this looks like a mouthful, but if you break it down, it makes sense. Osteoporosis is a systemic skeletal disease, and systemic means it doesn't just happen in one place. Characterized by low bone mass, which we saw in the last slide, and microarchitectural deterioration of bone tissue, which we're going to see in the next slide. As a result of that, the deterioration of the structure of bone tissue, there's an increase in bone fragility, and that individual is more susceptible to fracture. Now, one of the points that we want to make here is that osteoporosis is not osteoarthritis. Osteoarthritis is a disease of joint tissue. Osteoporosis is a disease of bone, and they are separate. Osteoarthritis usually is quite painful for individuals. Osteoporosis, bone loss, and the deterioration of bone structure, that doesn't hurt. What does hurt when you have osteoporosis is when that bone breaks. So on the next slide, we have a picture that actually shows us what we're talking about with changes in the microarchitecture of bone. On the left, you can see a normal healthy bone where there's lots of what we would call cross-linked or structural material. They're plentiful and they're thick. That bone is strong. On the right-hand side, you can see that many of those cross-links are gone. The ones that are there are much thinner than they were in the healthy bone, and also some of them that are there are broken. So that is osteoporosis. Osteoporosis, the bone loss, this process doesn't hurt, and osteoporosis is often called the silent thief because there are no symptoms associated with this process or the ongoing deterioration of bone until an individual has a fracture. In the next slide, we can see that there are two types of osteoporosis. Primary, associated with menopause and aging. And if you think back to the picture of the bridge with the honeycomb structure and the slide that we just looked at with deterioration, it's that honeycomb type of bone that is most affected by bone loss associated with aging and with menopause. Secondary osteoporosis is just as it's described. It's bone loss that's associated with or secondary to something else, to either a health condition, disease, or drug therapy. And it doesn't matter what the cause of the osteoporosis is, the consequences are the same, and that is an increased risk of a fracture. Now on the next slide, we have a look at the common fracture sites. The most important message on this slide is on the right-hand side, and it's in red. After age 50, over 80% or almost all of fractures are caused by osteoporosis. The most common sites of osteoporotic fractures are highlighted for you in green: shoulder, spine, and those would be the vertebrae in the back, the hip, which was the picture we looked at and compared to the bridge, or wrist bones. And the reason for that is that these are all sites that are rich in trabecular bone. Fractures of the skull, hand, ankle, and foot are typically not associated with osteoporosis. Or if you fall out of a tree or in a car crash, that generally isn't an osteoporotic fracture either. Okay, on the next slide, we can see one of the most common fractures that is an early warning sign of osteoporosis. Once again, in red in the middle of the slide, fragility fractures are the most serious sign of osteoporosis. Fragility fractures are broken bones that happen with something as simple as slipping, tripping, falling from a standing height. Bones should not break when you fall from a standing height. And I'm sure many of our participants today either have had this kind of fracture or know someone who has had. And the reaction of that individual to the suggestion of an osteoporosis test is, oh, I just slipped, it's fine. Maybe it is, but maybe it isn't. A fragility fracture should trigger a bone density test. Another place where we can see signs of osteoporosis ourselves is in the next slide with height change. Spinal fractures, and if you have a look at the change in the shape of those red spines, you can see as that skeleton moves to the right, that individual is getting shorter and shorter. Height loss is often associated with back pain, which can impair the activities of daily living, sleep, etc. But the fact that it's associated with back pain, that these are often mistaken for just a backache, a pulled muscle. These are called compression fractures, where the spine bones crush, again, because of the loss of structural integrity, and leading to height change. So just as the wrist fracture should trigger exploration or assessment for osteoporosis, so does height change. And in the next slide, we can see what are you looking at as an indicator of possible osteoporosis. And I'll start out by saying that we should all have our height measured every year by our healthcare provider so that you can track these kinds of changes and note a severe change in 1 year or a change over time. Individuals who have lost 3/4 of an inch in height in 1 year, or about 2 centimeters, or if since young adulthood individuals lose 2.5 inches in height, it should trigger a spinal x-ray to see whether or not that height loss is because of those spinal crush fractures, which would then lead to assessment for osteoporosis. Okay, and the next slide, we'll have a look at the most severe fractures, the hip fracture. One of the things that we know about hip fractures is usually people have had early warning that was not recognized. Again, you can see in red that these individuals likely had a hip fracture, or sorry, a wrist fracture. They may have lost height. They may have had a fracture of shoulder, which was not explored as a possible fracture because of osteoporosis. And in those cases, if it had been identified and treated with osteoporosis medication, these hip fractures can be prevented. Osteoporosis is often considered a disease of older women, but we know that men are affected as well. And about 1/4 of hip fractures take place in the male population. We know that men who suffer hip fractures are more likely to die relative to women who suffer hip fractures. Almost half of hip fracture patients, men or women, do not return to independent living, and 1/3 will have another fracture within a year. So if hip fractures can be prevented with early diagnosis and treatment, it's a really important change for individuals, and it's also a huge saving for the healthcare system. Now, the fact that osteoporosis has often been thought of as a woman's disease fits right in with the theme of our webinar today. That's a myth. We do know that 1/4 of hip fractures occur in men. They're absolutely affected by osteoporosis. And with that, our first myth dispelled, I'm going to turn the webinar over to our Mythbusters to take care of the next 4 areas.
Thank you very much for that wonderful introduction, Pat, and to the organizers for bringing attention to such an important area. My first myth is that everyone can manage osteoporosis with diet and exercise only. And this is a myth that I wish was fact. Everybody has heard about the importance of diet and exercise, and that's not a myth. Diet and exercise are very important, as you'll hear from me and subsequent speakers. But unfortunately, you can do everything right and still get osteoporosis. The reason for this is, unfortunately, in our genes, and we can blame our parents for that. 75% of our bone strength, our bone density, peak bone mass that you heard about is actually inherited. So unfortunately, although diet and exercise will be important in the management of osteoporosis, doing everything right does not necessarily protect us from getting that. I'll advance to the next slide. That's why the Osteoporosis Canada guidelines in 2010, in their integrated approach to management of patients at risk for fracture, highlighted at the very beginning for everybody, basic bone health. Basic bone health begins at age 50 or individuals at higher risk for fracture and includes weight-bearing exercise, and you'll hear some refinements to the exercise strategy, the use of calcium, preferably from diet, but also supplements if necessary to achieve an optimal level of 1,200 milligrams of elemental calcium per day, and optimizing vitamin D status. Usually that's through a supplement, and there's some debate about the amount, but the Osteoporosis Canada recommendations are that 800 to 2,000 units per day are likely to get people to where they need to be and is definitely safe. And don't forget the importance of fall prevention, because falls contribute to most of the fractures, especially the fractures that can kill patients, such as hip fractures. Please advance. This is a summary slide of the vitamin D and calcium research that the Osteoporosis Canada Scientific Advisory looked at in formulating its recommendations. This is a bit of a complicated plot, but the line in the middle shows the effect that you would see taking no active treatment, no active calcium or vitamin D, And anything to the left of that, and you can see most of those dots and lines are to the left of that, means that there's a significant reduction in the risk of fracture. And so when you combine multiple large research trials, because no one research trial gives you truth, but if you combine multiple trials, you start to get a good sense of what the truth is, that the combination of all these studies showed that there was a significant reduction in the risk for fracture, about an 18% reduction in the risk of fracture. Keep that number in mind because we'll compare that to what is achieved with medications added to diet and exercise. Next slide. Exercise is very important, and there are more refinements coming to the best exercise, as you'll be hearing in the 2020 guidelines when they're eventually finalized and released. But in 2010, we highlighted the importance of regular exercise programs. Aerobic strength training are particularly important. They have positive effects of bone density, but can't cure osteoporosis. They can help with improving posture. They may not directly affect fracture prevention, but they can reduce falls, and falls are so important in fracture risk and hip fracture risk that we definitely favor the importance of exercise for maintenance of balance and for strength training. Next slide, please. This is what you can achieve with medications added on top of the usual good health prevention strategies, including calcium and vitamin D. This is the largest recent study looking at all of the world's literature and comprised 107 research studies. I'll just drop to the bottom line that the approved therapies in Canada can reduce your risk of spine fracture by over 50%, hip fracture by 40%, and other major osteoporotic fractures by 33%, and that's over and above what can be achieved with calcium, vitamin D, and exercise alone. Next slide. And that's why the strategy from the Osteoporosis Canada guidelines is to highlight individuals at high risk, and that's on the right-hand side of the panel, individuals with high calculated fracture risk or who've already sustained major fractures, including fractures involving the spine, hip, or multiple sites, because those are the individuals where we think they will get the most benefit from drug therapy, although, as you can see at the top, everybody benefits from good diet, exercise, and fall prevention. Next slide. The next myth is that an osteoporosis test is painful and exposes you to a ton of radiation. Well, many of you have probably had one of these tests. I'll let you go on to the next slide. And you know from your own experience that these are no contact scans. You lay on a table, there's some positioning, and the scan itself is usually over in less than a minute. There is sometimes some discomfort with positioning the hip or the spine, especially if there's some arthritis, but for most patients, there's no discomfort whatsoever. It's simply the laying on a bed, waiting for the positioning to be perfected by the technologist, and then the scan is completed in usually less than 1 minute. Next slide. From those scans, you typically get a picture of the spine and a picture of the hip. It's not the picture that matters, it's the density of the bone, and that's what can be calculated using the very small amounts of x-rays that are coming from these scanners. Next slide. The amount of radiation that you get from these is exceptionally small, and I just want to highlight that radiation is part of our normal environment, part of our own internal organs. And so our bodies are well adapted to small amounts of radiation. I highlight in the middle of the slide the kind of radiation dose that you might get from a standard DEXA scan to measure bone density of the spine or hip, or if somebody ever goes for a body fat, body composition scan, that's even lower. And you can compare that with the amount of radiation that you might get from airport screening, from eating a banana, because bananas have potassium, and since the Big Bang, potassium is slightly radioactive, or even having somebody sleeping next to you who also has that radioactive potassium in their body. This is much less than the average background of radiation that we get from cosmic sources, from radon in the ground, from natural exposure in the environment, and definitely more than 10 times as small as what you get from a single chest x-ray, and much, much less than a CT scan. So these are extremely low radiation doses and therefore extremely safe. Thank you. There's the final slide, just showing if you ever thought about 4 bananas and worried about the radiation dose, that is essentially what we're talking about with a body DEXA scan to measure body composition and fat. So this really are phenomenally low radiation, very safe procedures. Thank you. I'll turn it over at this point.
Thank you, Dr. Leslie. My name is Michelle Glass, and I will be first reviewing the myth, everyone should take a drug holiday. So just a quick review first of who needs medications to treat osteoporosis. So Dr. Leslie touched a little bit on the different risk categories. And so men and women at high fracture risk, which means that they have a more than 20% chance of breaking a bone within the next 10 years, are individuals who should be treated with medication. If you've had a spine or hip fracture or multiple fragility fractures, you are at high risk for more fractures and should be treated with medications. Now, who else may be treated with medications? Those who are at moderate risk, those are individuals who have a 10 to 20% risk of breaking a bone within the next 10 years. Those individuals who have other underlying risk factors as well may be considered for drug treatment. We're going to look at their gender, their age, whether they've had a previous fragility fracture. We're going to look at whether they've had certain cancer treatments or long-term steroid use, and other health conditions, and as well as family history. We're going to look at all of those things and decide whether medication is indicated for those individuals. So now, what is a drug holiday? A drug holiday is when a patient stops taking a medication for a period of time, anywhere from a few days to months or even years, if they feel that it is in their best interest. Now, it is a fact that all medications have a risk or side effects associated with them. And the important thing is to understand whether the risks outweigh the benefits of the medications. Next slide, please. Every time a medication is recommended or prescribed, a careful weighing of the risks and benefits associated with taking that medication should be reviewed with your physician and or pharmacist. So on this slide, you can see what are the benefits of treating osteoporosis with medications. Well, like Dr. Leslie mentioned, there's approximately a 50% fracture risk reduction when using osteoporosis medications. We know that it's going to improve or stabilize our bone density, and we know that high-risk patients benefit the most from drug treatments. Now, when you look at the risks, like I mentioned, no medication is free from side effects, and every drug has a side effect. And so you're always looking at the risks and the benefits. And safe medications mean that the benefits outweigh the risks for that individual person. You may have heard in the media there are some rare risks associated with osteoporosis medications. They include osteonecrosis of the jaw, which is a breakdown of the jawbone, as well as atypical femur fractures, and those are unusual fractures that occur in the long thigh bone. So there have been reports of those types of side effects after a long-term exposure to some of these medications. However, it's important to emphasize that they are rare. We're talking about 1 in 10,000, 1 into 100,000 people may experience these rare side effects. So there have been some concerns about these prolonged use of drugs that might increase the risk of these rare but serious side effects. So currently the recommendation is to treat with medication for approximately 5 years and then reassess the risk for fracture. And that will determine if the individual should remain on therapy or attempt a drug holiday. If a drug holiday is attempted, they should be carefully monitored and reassessed with a bone density test to see whether their bone density remains stable or if it starts to decline again, and then it'll be determined whether they should restart their medication. So that is when a drug holiday may be considered. Next slide, please. So at this point, I always like to remind people when you're looking at the side effects of medication, to always remember the statistics that 1 in 3 women and 1 in 5 men will suffer an osteoporotic fracture in their lifetime. And we know that these fractures are serious. They can often alter quality of life, they can worsen other health conditions, and in some cases cause death. So we know what the risks of osteoporosis are, and then we know what the risks of these rare side effects are. And so to put it into perspectives, I always remind people to look at the 1 in 3 women or 1 in 5 men in the room versus the rare side effects of 1 in 100,000. Next slide, please. The next myth is osteoporosis is always in your genes. It is true that there is a genetic component to osteoporosis, but there are other risk factors for developing weak and porous bones, as well as falls that contribute to fractures. These causes or risk factors can lead to secondary osteoporosis, and this is when an underlying health condition, a medication, or a lifestyle factor that can contribute to developing osteoporosis. Next slide. I've listed some medications that can often contribute to falls and then secondarily a fracture. So many mood-altering medications such as antidepressants, anti-anxiety, antipsychotics can often cause people to be unbalanced or unsteady on their feet. It can contribute to falls, especially sleep aids or hypnotics. These are widely prescribed, and many people become unsteady on their feet, and especially when it's prescribed in the elderly. Often people will take a sleep aid before bed, they'll wake up in the middle of the night to use the bathroom, and then that's when there is a danger of being unsteady on your feet and having a fall. Blood pressure medications, they can often cause a drop in blood pressure from a standing or sitting or lying down position. And so this as well can often cause people to be unsteady on their feet. Painkillers as well can cause a lot of sedation, as well can contribute to falls, as well as some prostate medications that as well can cause low blood pressure and a loss of balance. Next slide, please. There are also many medications out there that can contribute to bone loss. Probably the most common example of this is oral steroids, such as prednisone. For individuals who are using those for more than 3 months, it can contribute to significant bone loss. And so many people are unaware of this and often are treated with long-term steroids for years without being treated for preventative measures to prevent osteoporosis. Certain cancer drugs, in particular breast cancer or prostate cancer medications, can contribute to bone loss. Another widely prescribed medication, acid blockers, those can contribute to bone loss because they reduce the stomach acid, resulting in decreased calcium and other mineral absorption. If your thyroid levels are not under control, excessive thyroid levels can contribute to bone loss, as well as certain anticonvulsant medications that are used to treat seizure drugs. Those are also medications that can contribute to bone loss. Next slide, please. Lastly, there are several health conditions that can contribute to bone loss or falls. Conditions that reduce the absorption of nutrients, including calcium and vitamin D. Those include conditions, inflammatory bowel conditions such as celiacs, Crohn's, colitis, irritable bowel, as well as bariatric surgery. Those can hinder the absorption of nutrients, including calcium and vitamin D. Arthritis conditions that affect the joints, that can cause poor balance, or people often give the description that their leg gave out, and that can contribute to falls, and that's often due to osteoporosis. There are neurological conditions such as cerebral palsy, Parkinson's, or MS that can lead to poor balance and gait problems that can contribute to falls and then broken bones. Neuropathy of the feet and legs resulting in poor balance. Often diabetics can develop neuropathy in their feet, and that can put them at risk for falls. Low blood pressure, kidney disease, as well as conditions that result in immobility, such as stroke, spinal cord injury, and MS. These are all different health conditions that can contribute to either bone loss or to falls. Next slide, please. So we know that genetics does play a factor in developing osteoporosis. However, you can see that there are many underlying factors that can contribute to osteoporosis and fracture risk. I will now introduce Amanda Hamill, a registered dietitian.
Thank you, Michelle. That's wonderful. So I only have 4 slides, but that doesn't mean I don't have a lot to say when it comes to busting myths around nutrition. So the first myth is that nutrients from supplements are just as good as those from food for building and protecting bones. So have you ever thought, gosh, I wish there was a magic pill that would give me all the nutrients I need? And let me tell you, when life gets busy, I know I've thought about this even as a dietitian, but in reality, there is no magic pill. And honestly, what fun would that be anyways, right? Just eating a pill. So we know that eating a variety of foods in general is really important for bone health, and it's almost always better to get nutrients from food rather than pills. And I know that my previous panelists have talked about this as well, but I'm just going to dive into the 3 key bone healthy nutrients, which you probably know as vitamin D, calcium, and protein. So when it comes to vitamin D, this is actually not a myth. So Osteoporosis Canada recommends a vitamin D supplement every day, all year round. And the reason for this is that we just simply can't get enough vitamin D through food sources alone. And also, given our current situation, we're also likely not traveling anywhere warmer anytime soon. And we live in a northern country where the sunlight is a very inadequate source of vitamin D. So what you can do is take a vitamin D tablet every day, but just make sure to talk with your doctor or pharmacist about the type and amount that is best for you. But in general, as Dr. Leslie alluded to, about 1,000 international units per day is good enough for most people. So like I said, when it comes to vitamin D, that's really crucial to help your body absorb enough calcium. So when we look at calcium, supplements are not equal to or better than food as a calcium source. So I'll just say that again. Supplements are not equal to or better than food as a calcium source. So the calcium in food comes packed with many other nutrients that are important for bone health. And so Osteoporosis Canada encourages people like you and me to get as much calcium from food as possible every day. But the thing is, if you're not able to get enough calcium from food, you definitely want to consult with your doctor to consider adding a supplement in to make up for the difference that you're not getting. But how do we know if we're not getting enough? Hopefully you've checked out Osteoporosis Canada's website. There is a fabulous resource called the Calcium Calculator. It's a free online resource where you can literally plug in everything that you eat in a day, and it'll add up how much calcium you consume from food. There's also an app for that too. So through the BC Dairy Association, you can download the Calcium Calculator app if you like to use your phone for that kind of thing. So if you don't get enough calcium through food, also ask yourself, what are some simple ways that I can increase my calcium intake? Maybe it means adding some milk powder to your oatmeal in the morning, or adding an extra calcium-rich snack throughout your day. So Osteoporosis Canada also notes that milk products are a great source of calcium and protein. So they're what we call calcium-dense foods. So they give you a lot of bang for your buck when it comes to calcium. But in addition to that, there are also calcium found in other foods, such as calcium fortified food and drinks, and also in lesser amounts in some fruits and veggies, nuts and seeds, and of course, legumes. So if we're talking about protein, so we just talked about calcium, protein is another important bone healthy nutrient. And once again, when it comes to this myth that you see on the screen here that supplements are just as good as food, it's also a myth when it comes to protein. So you've probably heard about all the protein supplements on the market. They're usually targeted towards athletes, but also towards people who want to boost their protein. But again, it is a myth that the protein from supplements is just as good as what we get from food. So if I can break down the science a little bit, all of the proteins in the food that we eat and the protein structures in our bodies are made up of these tiny building blocks called amino acids. And when we eat protein from any source, including things like collagen, I'm sure you've heard of all the collagen supplements out there, what happens is our digestive system breaks down those building blocks into those tiny amino acids. And our body uses those building blocks to maintain and repair our own tissues. So really, our body doesn't care where that protein source is coming from. But what we do know is that eating a protein-rich meal every day is very important to making sure that we're getting the building blocks that we need for our body tissues. So some good quality sources of protein you're probably familiar with include your milk products, dairy products, eggs, meat, fish, and of course, plant sources such as chickpeas, kidney beans, pinto beans, soybeans, tofu, and many more. So next slide, please. The bottom line here is that food is truly your best bet when it comes to calcium and protein. And it's really important to know that extra calcium from food is not harmful, but there is a potential for extra or too much calcium from supplements to become harmful. And if you are already getting enough calcium in your diet, there is definitely no need to take a supplement. So save your hard-earned cash. Next slide, please. So the next myth here is something I hear a lot as a dietitian. You're probably familiar with a lot of popular diet trends, and the keto diet and intermittent fasting come up a lot. So the myth here is that the keto diet, intermittent fasting, maybe some other diets out there are safe for those with osteoporosis. So just going on to the next slide here, I just want to show you a plate. So take a look at that plate. And let's assume that this plate represents the typical keto diet. Do you see sources of protein and fat? Probably yes. How about adequate or quality sources of calcium? Not really. So let's rewind back just a little bit. What is a keto diet and why is it so popular? So the keto diet has actually been around for many, many years, but it was originally started to clinically treat children with severe epilepsy or seizures. But it recently became popularized, of course, by the diet industry as, you guessed it, a weight loss diet. You can almost hear the dollar signs rolling in. So the premise is that by eating a high percentage of fat in your diet with a very low percentage of carbohydrate, you know, your breads and grains, that kind of thing, your body is forced to use fat as fuel for energy instead of glucose, and therefore you lose weight. But, and this is a big but, this dietary pattern is really not sustainable in the long term for many, many people. And in addition, a true keto diet lacks in variety, as you can see on that plate. It lacks in vegetables and fruits, whole grains, and certainly high quality calcium sources such as milk and dairy products. So the bottom line here is that the keto diet lacks in variety and those calcium-rich foods, which are essential for optimal bone health. And then lastly, without getting into too much detail about intermittent fasting, again, it's one of those fad diets that has been popularized in social media, again, for the purpose of usually weight loss. But there are really a lot of unknowns when it comes to these diets, the keto, intermittent fasting, and really what my message to you is that it is not recommended, especially for an at-risk population. So we really do not understand the long-term effects of these diets on bone health simply because there is a lack of research, and also people just aren't able to follow these diets in the long term. And they're very restrictive, which could mean that you're not getting enough of those three bone nutrient or bone helping nutrients such as vitamin D, calcium, and protein. So the bottom line here is right up on the slide there. So Osteoporosis Canada recommends following a more balanced plate using Health Canada's food guide for a more balanced and sustainable approach to get those bone building nutrients. And so with that said, I'd like to pass the mic to Emily Hunter, who is our physiotherapist.
Come on. Thank you, Amanda. My first myth, my bones should be strong, as I was a very active child and walked daily as an adult. Next slide. The great news is this person achieved a good peak bone mass as a child and adolescent. This is exactly what we want for each of our young people. This graph, as Pat showed you before, shows how our bone mass can continue to improve to our early 20s with good nutrition and activity. Our job now as an adult is to maintain that bone mass and strengthen it. You can see that bone mass, excuse me, in women decreases more quickly than men's usually. The osteoporosis diagnosis is based on both a bone mineral density test, BMD, and a fracture risk assessment, Fracture Carrick. These combined show a fracture risk of low, medium, or high, and will determine what exercises are safe for that client. Walking is a great exercise that combines weight bearing, balance, and aerobic exercise at the same time. But walking is not enough. This person needs a full body program. Your bones and muscles respond better to different activities to maintain or improve strength, rather than the same activities day after day. Bones like to be surprised. So by changing your walking pattern with different speeds and terrain, and by adding other activities like dancing, Tai Chi, or playing soccer with a grandchild, your bones in your legs and lower back will be healthier and stronger. Next slide. Good balance is important to keep us from falling. Most of us no longer test our balance like we did as children. Order a copy of the booklet, Too Fit to Fracture, or refer to it on the Osteoporosis Canada website to get great tips on balancing exercise. I have an exercise for you. The next time that you brush a carrot or your teeth, stand on one foot without leaning on the counter. These are both a great start to your daily balancing program to be done throughout your day. Work towards being able to hold that position for 15 seconds or more. Your spine and upper limb bones also require exercise to maintain and improve bone strength. Again, the Too Fit to Fracture booklet, pages 3 to 6, will give you some great tips on trunk and upper body strengthening. I would also encourage you to work with a physiotherapist or fitness professional who has been trained in safe exercises for the older adult to develop a program specifically for you and your abilities. This person will teach you proper techniques of each exercise and the exercise safety rules if you are osteoporotic. To decrease your chance of injury when exercising, your coach will also teach you proper body mechanics for different activities in your house and yard. Your booklet, pages 28 to 32, outlines spine-sparing techniques. These techniques and proper exercise prevent spinal fractures. You too will become a team. Remember to do a variety of exercises that work your entire body. Next slide. Myth number 2 for me, after being diagnosed with osteoporosis, you must discontinue most exercises and activities to avoid breaking a bone. This is a very difficult myth to overcome, as the fear of fracturing becomes their focus. Use it or lose it is a motto that muscles and bones live by. Next slide. Just like our previous person, there are 4 types of exercise that we need to do for healthy bones. Number 1, strength training for the entire body. You can do strength training using exercise bands, free weights, or your body weight for resistance training. Next slide. Number 2 is balance exercises. Next slide. Good. Balance exercises. Throughout your day, practice your balance. You will be surprised at how quickly it improves. Next slide. Posture exercises. Great posture in sitting and standing decreases pain and decreases your chance of falling. I have an exercise for you. Sit up straight and place your feet on the floor. Pull your belly button in as if you were doing up a loose pair of pants. Lift your breastbone up towards the ceiling and level your chin. You will feel your shoulder blade tips pull together slightly. Continue to breathe normally throughout this exercise and hold it for 5 to 10 seconds. This is a great posture exercise that we should all do often every day. Next slide. Number 4 is aerobic and weight-bearing exercises. This will be your walking, your Tai Chi, your dancing activities. Remember, biking and swimming are great activities, but are not weight-bearing exercises, so do not benefit your bones as much. Next slide. The fearful client needs a fitness professional who will start a gradual, safe education and exercise program designed specifically for them to give them their confidence back. This will give them their life back. The professional will review and explain their bone mineral density test and their fracture risk assessment that is found on the BMD results. This shows both what the client's fracture risk is and the program can be tailored to that person. Without this intervention, with a professional, the client risks more strength and bone loss and will have a higher risk of fracture and may become dependent on others for their care. A once-a-month visit to check progress and increase their program will be an excellent way for this person to resume their favorite activities safely and with confidence. Live your passion, whether it is volunteering at the local food bank, going for a walk with a friend, gardening, or playing a game of golf. Almost any activity that was enjoyed prior to your osteoporosis diagnosis can be restarted with proper coaching. The fearful client will need more time to reach their potential, but this process is well worth the time and effort by the client and the coach. Being strong maintains our independence as we age. The Osteoporosis Canada website is a fabulous support, and each province has a staff person and trained volunteers to answer your questions. Stay safe, stay active, live your passion. We will now return to the moderator, Pat McCarthy-Briggs.
Okay, thank you very much, Mythbusters. I'm going to ask all of you to turn your webcams on, and we'll have an opportunity to see our panelists as they answer questions. Okay, the first question, I'm going to throw this out to Bill and or Michelle. Question or the statement is, I've been diagnosed with osteoporosis and prescribed medication, but I don't want to take it.
Great. Okay. Hi. Can you hear me now? Okay. I guess I'll address that. I mean, lots of people don't want to take medications for a variety of different reasons. And I guess the first step would be is to address what are your apprehensions? What are you worried about? Are you just concerned that you just don't want to be a pill taker, or are there certain side effects that you are concerned about? Those are conversations that you need to have with your physician and or pharmacist to find out what are the real risks are, what are your real concerns with taking osteoporosis medications, or is it medications in general that you have concerns with? So there's lots of things to discover and talk about. So, but that would be your first steps.
I agree with all of that. And just to highlight that you're not alone. There are a lot of people out there that have questions about medications and especially making a long-term commitment to a medication, because osteoporosis is a chronic disease. One shot or one course of treatment is not going to fix it. And so you need to understand in full the benefits and the risks, and make your own choice in consultation with the healthcare professional. But be aware that other people face the same difficult decision making, and that there are a variety of treatment options that are available to align with your lifestyle. Some can be taken weekly, some once a year. So there are a range of options for you.
Okay, thank you, Bill and Michelle. A question for Emily. Is running safe after an osteoporotic diagnosis?
So good question. Is running safe? It depends how well you run. If you run like me, no, it would not be safe, because it would be horrible to watch and it would be too much compression. But I've treated runners who have become osteoporotic for whatever reason, possibly because they only ran, and they want to continue running. So if they're a very, very smooth runner with fabulous foot shoes, then with good support and good decompression, then I would say they could continue to run. But you shouldn't be starting a running program if you are osteoporotic.
Amanda, did you hear that? Nope. Oh dear. Okay, this is a question for Amanda. How many cups of coffee per day are safe? How many beers per week are safe?
Oh, caffeine. Yeah, so this is a time to look at how big your cup is, for sure. So if we look at Health Canada recommendations, 2 to 3 cups of coffee, which is about, if I'm not mistaken, 200 to 300 milligrams of caffeine per day. And the reason for that is that caffeine can block the absorption of calcium. So we just don't want to be drinking pots and pots of coffee. That's the main point there. And the second part of the question?
The second part of the question was how many beers per week are safe?
Beers. So it depends whether you're male or female. But for females, when it comes to alcohol, one serving, no more than 1 serving per day. And for males, 1 to 2 servings per day. So for beers, that's 1 standard size drink. And again, the reason for that is to inhibit calcium.
Okay, a question for Bill. Has there been follow-up testing to see if calcium and vitamin D recommendations are resulting in fewer bones broken?
Well, the good news is that we've looked at hip fracture rates for all of Canada and tracked those over decades and shown that, in fact, hip fracture rates in Canada have been going down steadily. It's interesting to try and guess why that is. We don't really understand. Some of that decrease in hip fracture rates began before the osteoporosis medications that we currently use were available. So we think it's connected to some sort of lifestyle changes, and maybe that's the factor. That's a very good question.
Okay, thank you. Question for Michelle. What type of calcium supplement is best, taking with food or without food?
So that's a good question. There's a lot of different varieties of calcium supplements. They come in tablets and chewables and liquid form. And there's different forms of calcium. And depending on the form of calcium will determine whether you need to take it with or without food. And any bottle or package that you purchase at a pharmacy or health food store, it'll have those instructions on the label, whether you should take it with or without food. Probably the most common form of calcium is calcium carbonate, and that is a form of calcium that must be taken with food in order for it to be absorbed. It needs the acidity in your stomach that's initiated after eating in order for the calcium to be absorbed by the stomach. There are other forms of calcium, like calcium citrate, that can be taken regardless of food. And often individuals who are taking certain medications like acid blockers, I will recommend that they take forms of calcium that don't require to be taken with food, such as the calcium citrate, and it's more likely that they'll get some better absorption from those types of calcium. So there's a variety of different types of calcium. You have to read the labels, and sometimes it just depends on your lifestyle, whether you want to take it with or without food or any time of day. So there's lots of choices, and I always recommend to get assistance, from your pharmacist or healthcare provider to help you choose the most appropriate one for you.
Okay, thank you, Michelle. Emily, one of our participants likes to stand up straight every morning and touch his or her toes 10 times. Should they keep doing this?
I'm afraid not. You shouldn't continue to do this. I think in my mother's time, this used to be taught in school every morning to get the kids loosened up, but it puts tremendous pressure on the front of the vertebra, because usually when people bend forward, they round their backs moderately or excessively. And this you want to avoid if you're osteoporotic. So go and see a professional, and they will definitely help you change that exercise and still get the same benefit of, stretching out your back muscles or stretching out your hamstrings and giving you a different way to get your motor running in the morning.
Okay, we have a question for Bill. This is after a day of sitting working on a computer or a day of yard work, whether or not back pain is a sign of bone erosion or some of the things that we saw in the earlier slides today.
Well, the many things can cause back pain, of course, and if the back pain is connected to osteoporosis, it's because there's a fracture or compression in the back. That's usually can be painful for a period of time, but decreases. Interestingly, most spine fractures occur fairly gradually and may not be that severely painful. Causes of back pain, I think, that are persistent, that last more than a day or two, and that are really interfering with normal activities, need to be evaluated by a healthcare professional. That may lead to a spine X-ray to see what's going on, because there are many things other than fracture, of course, that can contribute to back pain.
Thank you, Bill. And next question is for Emily. I've heard that pole walking strengthens bones. Is this true?
Pole walking is an excellent suggestion. So whoever asked this question has it all together. So using poles to walk uses about 80% of your body's muscles. So that means it's also putting some stress through the 80% of your body's bones. So definitely, there are different people that can show you how to pole walk properly and have the right height to your poles, but this is an excellent way to strengthen the entire body if your main activity is walking.
Okay, I'm going to direct this one to you, Bill. Why are the calcium recommendations or calcium targets lower in the UK than they are in Canada?
It's interesting when we look at calcium and vitamin D and what's optimal. There is some uncertainty. We know that too little is to be avoided. Too much is not helpful, and there's a middle ground there that does have some uncertainty. If calcium and vitamin D were to be marketed as a drug, we'd actually have a very definite answer on that, because you'd have to do the dose finding research to say what is the optimal level. Unfortunately, nutrients don't qualify for those kinds of rigorous studies. So we're left with not the highest level of evidence to make that determination. The use of 1,200 milligrams from Osteoporosis Canada follows the Institute of Medicine, which was a very authoritative international comprehensive research. And so that is what was adopted by Health Canada. And we feel that it is appropriate for the Canadian population.
Great, thank you very much. Last question here, I think. Last question, second last question. But a question that I'm going to toss out to Amanda and Michelle, and the question is whether or not vitamin K2 is important to be taken with calcium. And I will start with Amanda, and then you can hand it over to Michelle.
Yeah, so there are two different types of vitamin K. There's K1 and K2. There is some research to suggest that vitamin K2, and you can correct me if I'm wrong, Michelle, that K2 is more protective of bone health than K1. But that being said, from a dietitian standpoint, it is definitely possible to get all of your nutritional vitamin K2 from food. So some sources of vitamin K2 would be like your dairy products, any meat products, poultry products, fermented foods as well. So it's possible to get that from food, but I'll pass it to Michelle from a pharmacist standpoint.
Oh, can't hear you, Michelle.
Oh, sorry about that.
There.
No, I defer to Amanda. As far as the expert goes for vitamin K, there's been no studies to suggest that you need to supplement that as far as bone health goes. And so, yeah, I defer to Amanda's expertise.
Okay, the last question I'm going to direct to Emily, and if anybody has anything else to add, please do. This would be for someone who has osteoporosis and has had the change in the upper back, kyphosis with that curve that associated with spinal fractures. My clothes don't fit well now due to the hump in my back. What can I do?
So the increased hump on your back is called increased kyphosis or hyperkyphosis. It's sometimes caused from just weakness where we slump and can't be bothered to sit up straight, but sometimes it's caused from compression fracture where the front of the vertebra has been compressed. And now that spine can no longer be upright or as upright as it should be. We should all have a little bit of curve in the upper back, but not excessive. So what happens when you get that? I would, again, talk to your professional, see if some posture exercises will help you. If it's just from weakness, you will be able to improve your posture well, and your clothes will fit better. If it's from the actual compression fractures, you still want to strengthen the back so that they don't get worse. And you want to probably see a dressmaker and have her or him fit that dress or that blouse or that jacket a little bit better, because it can be a big problem. With kyphosis, you will have some height loss, so you may have to, again, have a dress or a coat hemmed a little shorter.
Okay, that is our last question. Thank you very much, participants and Mythbusters. Our last slide has information for you about your regional community education engagement coordinators. If you have questions that you think of immediately upon ending this webinar, here's who to call. The BC Alberta Region Coordinator is Liz Kaler, Saskatchewan and Manitoba Sandy Oswar, Ontario Kathy Pierce, and East Canada and Territories Heather Easton, who's also been helping us with slides today. Thank you very much, Heather. There's a 1-800 number across the bottom of the slide and an information email for Osteoporosis Canada. I'd also encourage you to go to Osteoporosis Canada's website, which is osteoporosis.ca. It's a wonderful website, very robust with respect to information, and if spend enough time with it, you can probably answer every question you could think of with respect to osteoporosis. So thanks again to Heather for the slides, for Matthew for our IT support, the 4 Mythbusters, and you for participating.